Hi, Nerve Nerds. It's Kevin Zoe here, and I'm really happy to present today's ASPN Nerve Nerd Pioneer, Dr. Tessa Hadlock. Dr. Hadlock is the director of the Hadlock Facial Nerve Center in Boston, USA. She's a professor of otolaryngology at the Massachusetts Eye and Ear Infirmary and Harvard Medical School, and she's just truly a tour de force trailblazer in the field of facial nerve pathology and facial reanimation. She's trained so many people around the world, including myself, and she just got back from Peru on a mission just to kind of show you guys how much of an influence and impact she has around the world. So we're really, really delighted to have her here with us today. And thank you, Dr. Hadlock, for being here.
Thank you so much for having me. I really appreciate it. It's an absolute pleasure to be considered a nerve nerd.
I was hoping you could just start off by telling us a little bit about yourself. Where did you grow up, and what was your childhood like, and how did you go into university and medical school and so forth?
Of course. Well, I grew up. My parents are from Brooklyn, New York, sort of one step away from kind of immigrants, and they were sort of kind of from that more like working class background, but that really emphasized education. So my parents actually both have PhDs. My father is a mathematics professor, and my mom was a PhD psychologist. And so, needless to say, in my household, we like really emphasized kind of like education. And the other thing we really emphasized was like do it yourself ness. So I grew up learning how to do things like a lot of heavy construction, carpentry, masonry, all kinds of like really manual things. And so when I got further along in my education and I alighted upon medicine, I feel like a lot of the craftsmanship that I had grown up with sort of dovetailed into a career in surgery. So that's sort of how I alighted upon at least making that initial decision between like medicine and surgery.
Hmm, cool. Yeah, I never knew that. Do you still do any woodworking or masonry in your spare
Tons
time?
of stuff. Yeah, tons of masonry, carpentry, electrical work, shingling, like you name it. We
Wow.
grew up how to do it. And even though now I don't embark on really huge projects the way like we built our own house growing up, and even though I don't embark on that scale of a project now, if we're having work done, I can look at it through a much more trained eye. So in that sense, all that background kind of has paid off, even though I'm not really in the trades right now.
Very cool. Very cool. And so you talked about your entrance to medical school, and how did you discover otolaryngology, and why did you decide to pursue that?
Yeah, I mean, I loved all areas of surgery. I actually initially went into general surgery out of medical school because even though I loved otolaryngology and head and neck surgery in particular, and even things like neurosurgery and orthopedics and urology, those kind of ancillary things, I got married really young. We were first year medical students when we got married. So we were involved in the couples match. And this is kind of dating myself quite a bit, but back 35 years ago when we were matching, ENT was an early match. And so that's not something you can really do in the couples match. So I instead elected to just do general surgery. But then, fortuitously, halfway through our internship years, my husband looked at me and said, "I like hate orthopedics." And I said, "Great, I hate general surgery. Let's like switch." And so he switched into internal medicine. I switched into ENT, which was kind of like my passion out of medical school anyway. And we both didn't really miss a beat, but that allowed us to come like back from Chicago back to Boston, where we had trained in medical school. So we got kind of sent to Chicago for because of that kind of couples match situation. And so running back to Boston was really lovely because I had so many like family supports and a lot of good research infrastructure here that I had left behind to
Hmm,
go to Chicago.
very cool. And then what about your journey into facial paralysis specifically? How did you discover it? When did you discover it?
Yeah, so when I first came to Mass Sinai, literally my first rotation was facial plastic surgery. And I met a mentor, this surgeon named Mac Cheney, who basically put the problem right in front of my face. He showed me a video of a child with facial paralysis, and he said, "If you're going to pick a tough career problem, this ought to be it." And I was like immediately enthralled. I mean, obviously, he emphasized how inadequately the problem was being taken care of, like the inadequate surgical solutions that we had at the time. And I like to think that we've moved the needle somewhat on some of that over the past 30 years. But number one, it was sort of an unsolved problem. And number two, I had 2 years in the research lab between my PGY2 and the rest of my residency. So I could really start from the ground up working on kind of like facial nerve regeneration. So it was good fodder for research subject. And the other thing about facial paralysis that was absolutely mesmerizing was that it sort of sits at the intersection of aesthetics and function and human communication. So it's not speech and it's not hearing, but I consider it really paramount to nonverbal communication. So I really feel like it just covered so many bases within otolaryngology and plastic surgery.
Very cool. So you discovered facial paralysis early on in your ENT residency, and you kind of held it close to you. And then did you do a fellowship focusing on facial paralysis? Where did you do your fellowship?
Yeah, so I was a T32 resident here. So I had already done my surgical internship and I did my PGY2 year. That's when I kind of got bitten by the facial paralysis bug based on that great mentorship. Then I had 2 years in the research lab where I was able to focus on tissue engineering for nerve regeneration. And Dr. Cheney had connected me with Susan McKinnon during that period. And even though I couldn't really go to St. Louis to spend the 2 years with her, she was able to mentor me somewhat from a distance, along with a local tissue engineering surgeon, a guy named Jay Vacanti at Children's Hospital. So when I went into Dr. Vacanti's lab, I was surrounded by other surgical residents, each of whom had their own thing that they were trying to grow in a dish. So there were like the liver transplant type surgeons who were trying to grow a liver in a dish. And there was a pediatric surgery resident who was trying to grow intestine in a dish. And I was sort of there trying to grow nerve in a dish. And so we all had like the things we had in common were all of those things that we used our MIT colleagues for, biodegradable polymers, things that would biodegrade like very compatibly and gently so they wouldn't disrupt the microarchitecture of any structural element that you were growing. So we kind of each had a lot of those core biomaterials things in common, but then we were each kind of on a different branch of the tissue engineering tree. So once I had the 2 years of nerve regeneration research under my belt, and I really had my thoughts organized um, about nerve growth. Then, when I returned to the last 3 years of my residency, I was able to like start thinking like a facial nerve, if that makes sense. Just like thinking like, what are the problems that are unique to the facial nerve that are different, let's say, from brachial plexus or extremity, which is where so much of the research had been done. And again, as anybody who takes care of facial nerve patients knows, so much of the problem in facial nerve regeneration is about like directionality and sort of that target specificity in a mixed motor nerve. And so that kind of occupied the rest of my residency, understanding the problem, at least mastering the basic techniques that we had at that time. We were doing a lot of regional muscle transfer, T flaps. Free muscle for facial reanimation was a thing. And I went up and observed Ron Zucker and Ralph Magdalo and kind of got the basics down about how to do that. Dr. Cheney had done a few at Mass Eye and Ear, but really it was kind of at the very beginning of popularizing that technique. And then after I finished the residency, I did then do a microvascular fellowship so that I could feel really comfortable around like vessels and basically free tissue transfer in general for the head and neck region, even though those kinds of operations for oral cavity defects or oral oropharynx, cervical esophagus, and bony reconstructions were not really going to be um, they weren't going to be a major part of my reconstructive plan. I sort of had to go that route in order to develop the expertise that would make me a useful facial reanimation surgeon.
Wow, very cool. So you talked about your basic science training, talked about building these connections with pioneers and scientists across the city and even across the US with Dr. McKinnon, and then kind of honing your whole surgical armamentarium with the microvascular fellowship. So that's wow, that's really cool. And so when you came into practice and you started working and you started doing your first cases, what was that like? Was it terrifying, or were you like, I am so ready for this. I've got this. I know what to do.
It was so terrifying. That transition between being a fellow and being an attending was just for me a massive, massive transition. And that's in spite of the fact that I stayed where I trained. And so I had ongoing mentorship from Dr. Cheney, Dr. Varvaris, and many others. It's just that when you just don't have like daddy in the room for any mistake you might make, it's a big transition. I think surgeons all handle that very differently. I think there are maverick surgeons who are like, let me at it. I don't need any more teaching. And then there are people who are on the more tentative side, and that was me, kind of questioning sort of all my different moves. And I was sort of trying to innovate from the very beginning, but I didn't really have a very good hand. I didn't have like the wisdom of being like, let's say, a mid-career person who already kind of knew what worked and what didn't work. I think we all collectively didn't know what worked and what didn't work. And my early career was characterized a lot by kind of like reading the papers and trying to figure out what was known and unknown about facial nerve, which is really, really difficult because people, I still think our literature is plagued by this. There are a lot of papers out there that kind of sound sure, but they're not really sure. And you can imagine navigating that when you're 34 years old, which was, or 32 or 33 when I started out my attending career. It's just very hard to know what's baloney and what's actually the truth.
Mhm. Amongst the many things that you're known for is kind of pushing rigorous outcomes evaluation. So you were instrumental in developing Emotrix or FaceGram, as it was originally known, and also the eFace. Could you tell us a little bit about what your thought was in developing those scales, and are you happy having made those scales, and do you feel like surgeons are using them appropriately?
Yeah, I mean, I think at the beginning of my career, I was actually shocked that there were no tools to even figure out whether one operation or one approach or one physical therapy or Botox injections or anything was superior to the next thing. There were just literally no tools. But in my department, in my division, there was a guy who was a real guru in outcomes research for surgery. This guy named Rich Glicklick was became really well known in the surgical space and in the ENT space for outcomes research. I remember he ran one of the very first courses on outcomes research, and ultimately started to split his time between a company that he started called Outcome Sciences and his surgical career. So he was sort of inspiring in the fact that he knew that we needed these tools in order to number one, figure out what was best for patients. But number two, if we wanted to prove to insurance companies that we were helping anybody, we needed some kind of benchmarks. So this was sort of the right environment for that. And he and a visiting resident had developed this space instrument. It was kind of like a rudimentary quality of life scale for patients with facial paralysis, but in fact, it was very well designed. It was really rigorously validated. There were like focus groups before people knew what a focus group was. And so that survey is something we still employ. It lacks some of the modernities, but it still had like a lot of the important elements, and I still find it a useful tool. So he sort of helped he had published this space instrument, yet there was not a single publication except for the publication that described it. So from the very, very beginning, when I started publishing in the clinical arena, I made it a point to include patient reported quality of life outcomes. And then it was sort of a logical extension. Well, look, if we're going to report proms, we still need some objective measures, some clinician graded scores, et cetera. So we started with the eFace, and I really didn't publish the eFace until I had looked at over 1,000, probably more like 2 or 3,000 faces, because it was only then, let's say 10 years into my career, that I think I really had an amazing sense of like the entire spectrum of facial paralysis. Because it's really not until you see so many different things that you can start to think about like what kind of instrument would be useful. And it's one of my pet peeves that a lot of trainees and people very early on in their career start writing papers called like a novel scale for blah blah blah, and that can be a little bit dangerous because novel scales, when you don't have the wisdom to understand the full breadth of what a scale say is it's a little bit like of clutter, right?
Hmm.
Because then you've got people then reading that publication if it's out there, and they don't know if you're speaking from deep many years of experience or whether you just like have an idea.
Yeah, that makes sense. When you say the face instrument, do you mean the face scale, like the F lowercase a C E?
Yes,
That one. Okay.
the face scale or the face instrument is that initial quality of life instrument. We then, after we developed the e-face, then I started thinking more about like computer assessments. And so the precursor to the Emotrix program that some people are familiar with today was called the FaceGram, where literally I just teamed up with a graduate student at MIT and I said, like, these are the landmarks and these are the excursions that we really care about. And he was able to take like a very simple, just to build a very simple Java-based program that gave you a lot of those landmarks that you are interested in when you're doing facial reanimation. But funnily, even after it was published, it never really caught on the way that I thought it would catch on. I thought that once we had spent the time building this tool, every Tom, Dick, and Harry would be like, I need that instrument so I can figure out how well my brow ptosis corrections are doing or how well my eyelid weights are doing or whatever. Turns out nobody ever, really got that interested in it. And I don't know whether it wasn't user friendly enough or I wasn't the right voice perhaps for it at the time. I think this goes back 20 years when there was still more of a rigorous relationship between otolaryngologists or facial plastic surgeons and plastic surgeons. And there was a little bit of this, you're not in our family, and therefore we don't like your instrument kind of thing. I think the lines between those two specialties have been blurred, luckily, enough over the years, the dominant issue.
Okay. And what are your thoughts about the face Q, which is also a novel psychometric patient-reported outcome measure?
Yeah, I think the face cue is cool because it kind of fits into that whole modularity of what Andrea Pusick and others have really tried to develop. It's like you've got the breast cue and the face cue and the ear cue and it's like the idea that you're working on a problem and you just need to pull that module off the shelf and apply it makes a lot of sense. But again, until the face Q or the face instrument or the facial disability index or whatever the series of questions that you're going to be asking, until they are so incredibly easy to use that you just like trip over them on your way into seeing a patient, I still think we're going to struggle with getting the kinds of outcomes, with the frequency that we need them to really like make the big statements.
Yeah, I think it's always harder than we expect to actually implement these sorts of outcome measures universally to patients. Like we think, oh, it'll be easy, we'll just give them to all of our patients in clinic, but it actually involves a lot of effort to make sure patients fill them out, and you have to be mindful of how much you're giving patients to do as
Well,
well,
you're
right?
so right, Kevin. And that's something I didn't appreciate at all. I just was like dumbfounded why everybody wasn't doing the things that I was doing or developing. And it only dawned on me much, much later that I was at a place at Harvard where there were a lot of resources and there were a lot of opportunities to kind of set things up in a way that made that feasible and that a lot of people don't have access to the same levels of resources. But I'm not sure that it's a lack of resources that keeps people from getting a lot of these data. I think there are two other really important components. One is time. So people don't actually value spending the time to gather these outcomes data. They get so interested in like the sexy surgical innovation and so on to the next thing that they themselves don't commit to the time that it takes to get these outcomes measures. I don't think it's impossible for people to always get them, but I think that having clinicians prioritize them has been an issue. And the second thing is that in today's like medical legal climate, it's actually incredibly complicated to even administer an instrument. Even if you want to ask patients questions, there are all these funny roadblocks and have gone like way, way overboard in terms of like patient. I mean, I believe in patient safety and I believe in patient confidentiality, but at the same time, um, if you look at administering a quality of life instrument as a tool for clinicians, you can see that that's really the most important thing. And if you look at it through a lens of does this um, increase our institutional exposure to any kind of risk, then it becomes incredibly complicated to for people to feel that they can safely gather those outcomes data.
Mhm. Yeah, and yet you still persist. You persist and you find a way to measure them because you emphasize how important it is to gather this kind of data.
Of course, but that's taken, I mean, it's even taken shifting environments. I mean, I feel like even at Harvard, it became like I remember once a physician came to work here and she said, in my prior environment, that hospital made the easy things hard. So I never got to the hard things. And I thought, oh, well, here we make the easy things easy. And so you can get to the hard things. And I believe that was a correct statement at the time. But over my 28-year tenure or longer at Harvard, I think they actually started to kind of make the easy things hard also. Um, and I don't think Harvard is alone. I think that's happening across all kinds of academic institutions and all across the United States. And if it hasn't hit Canada or Western Europe or the rest of the world, it's coming for you. Now the easy things are hard everywhere. And I find that the most nimble environment that has the most freedoms to get appropriate consent from your patient, but then to also use their data in a way that's going to benefit patients worldwide, it's much easier
Yeah,
in a more of a private practice setting.
right. That makes sense. Let's shift gears. So this is an interview on ASPN, and you had talked about spending some time in the lab during your research years. Do you remember which year you first attended ASPN and what was that meeting like for you? Did you present? Did you meet anybody that you looked up to?
Yeah, I have vivid memories of ASPN because it was the only time that I had an opportunity to visit with Susan McKinnon live, with the exception of the twice that I traveled out to St. Louis to meet with her and she was helping me craft my KO8 award and things like that. So she at the time, she's a giant for me still, but she was such a giant for me then that I would get like sweaty palms just like thinking about like finding her and meeting her and wanting her to be proud of the things that I was presenting. And she was just like extraordinary because she like put me at ease, but like with a lot of tough love too. I remember presenting some of my research and she's like, look, this just isn't interesting the way you're approaching this. And there are other ways that you can do it. I mean, she didn't dump me, but she really guided me with some of that, with like a little bit of that steady hand. So she really characterizes a lot of my early memories of that meeting. It was actually the only meeting that I attended during my research years because the basic science quality of the otolaryngology meetings outside of otology was basically zero. It was like in the trash can. You simply couldn't go to the meeting and have anybody understand like what you were talking about or even care. So you'd be giving I would work for a year on a research paper and present it, and there'd be three people in the room, one of whom was like my mentor, and then my two co-resident. I mean, it was a lonely place. Whereas at ASPN, everybody was interested in nerve regeneration, and it just felt like an environment where people were really, really they could actually ask questions that would then um, get you excited to go back to the lab and try to help answer those things.
Yeah,
So for
yeah,
a while, that was like my main meeting. Of course, I was the only otolaryngologist at them. So, I'm not going to say I ate dinner with a lot of people.
yeah. No, that's great. I think talking with a lot of people, we all kind of realize how special ASPN is, how small it is, and how really focused it is, and how
Yeah,
multidisciplinary
yeah.
it is. I wanted to ask you just, you've talked about your 28-year or more tenure in facial reanimation. If you could highlight one or two or a couple kind of big advancements that you've seen or contributed to over this time period, what would those be?
Well, I think probably like three things. I think one thing is that I feel like I've contributed to making really aesthetic free muscle transfer no big deal. I feel like people see the results and they recognize that it's like totally doable. And I really like to think that I've contributed to really popularizing that across the United States. Now that I've trained and sent kind of into the world a lot of very competent fellows for that. So I didn't invent it and I didn't like describe a lot of nuances with it, but I have reduced it to practice in a way that I think makes it feel so realistic to lots of surgeons. Second, I think one of the really big breakthroughs, which I credit Vivek Azizadeh with, is sort of this whole concept of neurectomy or denervation or downgrading. And he did an amazing job sort of like innovating in that space. And what I've been able to add to that is to contribute a lot of numbers and apply kind of like the scientific rigor to it that sometimes it doesn't exist in all the different, you know, in all across all the different platforms where that surgery is done. So I kind of like learned it from him, but then really was able to drill into it deeply to try to make conclusions about like what makes it better, what
Mhm.
makes it more effective, what makes it more long lasting,
Right.
how can we make it more predictable, things like that. So I think that's like the second thing. And the last thing I would say, you know, what I'm really most proud of is the fact that I think that I can see on the horizon future in which a lot of these surgical interventions become obsolete because we have shifted to wearables and implantables. And I think that's still sort of in its infancy, but I can see like a cochlear implant of the face where we listen to or read or look at or record facial movements on one side and then drive those in kind of a mirroring effect. And even though we're not there clinically yet, I think our ideas are pretty well developed on that. And I would love to think that kind of the twilight years of my clinical career might involve more and more of that.
Wow, that's a awesome response. You answered my next question, which was kind of where do you see the next big innovation being? So that's
Yeah,
exciting.
that's where I think it's wearables and implantables, and I think we're not quite there yet, but I think that we can get there.
My last question for you, Dr. Hadlock, is for all the young trainees and the young surgeons that are watching this interview, what would be some advice that you would give to kind of focus on your craft, to build your practice, to get to where you are after years and years of hard work and focus?
I would say to people coming after me, you know, find your passion. I mean, I have found mine. Facial nerve is one such passion. There's a lot of room in that space for ongoing innovations and for young folks to come on board. But I would say be really, really thoughtful, more thoughtful than you think you need to be. Be thoughtful about your innovations and know that if you're thinking of something, somebody probably has thought of it already, and you want to really be careful about like experimenting on humans. You really want to be, you can't just try something without really considering in a broad context what could go wrong or what you're not delivering to a patient because you want to apply your idea.
Mhm.
And I would also caution people in the facial nerve space to be really careful about what they say in the literature because there's a big difference between this can work and this does work X amount of time. Because something that can work but works 12% of the time could send people all around the globe trying it um, before it's really before it's time.
Right.
And I think that in that sense, you want to kind of keep on listening to people who are ahead of you. And the other thing is, I think that if you're not keeping good track of your outcomes, photographically, videographically, and with these instruments, you really, it's shameful in today's day and age. You have to do it. I don't care how amazing of a surgeon you are. If you're not doing that, you're doing a disservice to the patients and the clinicians that are coming after you.
Okay. Great response. Well, Dr. Hadlock, thank you for an amazing interview. You shared so much experience and wisdom, and I think it's very clear how passionate you are about this topic. And I think all of our listeners will really appreciate you sharing all your passion with them. And you may
Well,
have some budding facial nerve surgeons listening today, so that's awesome.
thank you so much for the opportunity, Kevin. I really appreciate it.
All right. Thanks again, and hope to see you soon.
All right, bye.
Okay, bye.